My name is Jon Sassin, Jon, no H, and I'm a MD and a board certified neurologist before I got very involved in sleep, but that's how I got into sleep, was through neurology. I was drafted the day I graduated medical school in 1962, drafted into the United States Navy. And they told me, if you want to be an officer, give us a call. Otherwise, I'd have been on a ship somewhere. And they gave me what's called a Berry plan and allowed me to finish my residencies in internal medicine and neurology before I went on active duty in the Navy. So I entered the Navy in 1967 or something. About 5 years later, a lieutenant commander, and was assigned to the Navy's neuropsychiatric research unit in San Diego as the head of neurology division. And I got out there, and who am I working with? Vern Johnson, Artie Lubin, Paul Naito. We're all in that same division. But my skills and interests in electricity were not really as good as my skills and interests in a more, meaty, organic sort of process. And I got involved with endocrinology at Scripps, and we produced papers demonstrating the connections between neuropeptides and sleep, particularly human growth hormone and prolactin. And that sort of became my career in terms of research, was neuroendocrinology. And I presented my first paper in that to the APSS, which Vern was a big person in that. And the APSS at that time was the Association for the Psychophysiological Study of Sleep. Everybody loved that. And as we'll jump a little bit ahead, after that society was no longer important, it was the Sleep Center, the Academy, they wanted to keep the APSS in some form, so I and others devised this business of the Association of Professional Sleep Societies, APSS. And that's what our meeting is nowadays, I understand. Anyway, so I worked in the Navy in that field, and then when I was discharged, I accepted a position in the neurology department at Albert Einstein College of Medicine in the Bronx, and particularly because Elliot Weitzman was working there, and he was doing endocrinology work with cortisol and sleep cycles. And I went with Elliot, and we opened up a academic neurology department at Montefiore Hospital. And of course, that sleep center became a sort of a central sleep center till Elliot left and went up to Bloomingdale's. And of course, he died prematurely. And but I spent 5 years there, and then accepted a professorship at the University of California, Irvine, to help build a neurology department, training neurologists, do my research, and then got involved in academic politics, I guess you'd call it, and then ended up an associate dean of the medical school. So I spent a lot of time with administration and clinic and committees and stuff like that. But all with sleep in mind, and developed Sleep Center, and then became an important person in accreditation of sleep centers, which were now burgeoning. There was more coming up, and I worked with Helio Lemmy, who Dr. Lemmy was in charge of the whole country. I took the Western states, and I call myself the Johnny Appleseed of sleep centers, because I helped form and nurture lots of sleep centers out here in California, Oregon, Washington, Hawaii, all of those places. And eventually got up to where I was the president of this. By then it was the American Sleep Disorders Association. And the whole impact of sleep medicine came together in one word: apnea. Sleep apnea changed everything for everybody. No longer psychophysiological studies and EEG studies. It was let's look at airway obstruction and breathing disorders in sleep, and eventually caught the attention of pulmonary medicine doctors. Prior to that, it was a few neurologists, Elliot, me, and a few other people like that, and then some psychiatrists, a few psychiatrists, but it wasn't oriented toward that kind of medicine. So in 72, this is a memory of mine. In 1972, Elliot had decided, and I agreed, to sponsor the sleep meeting. And that was the meeting at Lake Minnewaska. And not everybody remembers that meeting, but what happened is the day of the meeting, the garbage truck hit a telephone pole and knocked out the power to this resort, Lake Minnewaska Resort, which was upstate of New York. And so the whole meeting was conducted by candlelight. And the resort made salami sandwiches for us. And it was very, very unusual to go to a scientific meeting where people were presenting in candlelight eating bologna sandwiches. Excuse me. And what I tell people about those early years, the 1979, 80, 81, into the 80s, because I retired my professorship in 1985 and moved up to here to Sonoma County as a wine grower, winemaker. The early days, we were very inclusive with the people who wanted to get involved in sleep. We wanted them to be part of this. And a lot of effort, particularly, of course, Bill DeMent, fronting that as the front man. A lot of effort at getting our board certification, medical specialty, subspecialty stuff, and the journal separated it. And then eventually the National Sleep Foundation, we sponsored that, and sort of brought sleep medicine into the world of medical practice. In those early days, I started having presentations at the meetings every year of clinical stuff, case presentations like grand rounds stuff, which most people weren't used to, but we started putting that into the sleep meetings. And eventually, as more and more pulmonologists, people like Meyer Krieger and got involved in it. It was very medical and very pulmonary, and still is. I mean, what else? When you think about sleep medicine, it's sleep apnea and some insomnia, but insomnia as a national program never really took off in the same way, and it still struggles with online sleep programs and sleeping pills, but the pulmonary stuff really took off, and then of course the institution of nasal CPAP and its use and treatment. Well, in a way there was a kind of a in the sleep center where there were so many PhD, non-MD type people who were important people in sleep and sleep physiology, compared to the MDs who were there for pulmonary and that there was always a kind of a clash. And I don't know if they still having that problem because I haven't been involved in the politics in a long time. But there was always a kind of a clash. And until Phil Westbrook started that Clinical Sleep Society, which turned things around, there was, it wasn't necessarily pleasant. And I remember there was also a group in Hershey, Pennsylvania. Tony Cale, what was Tony's name? Geez. Anyway, he had this idea about sleep that was different from Bill's idea about sleep. And they both had followers. And I remember a meeting in Tetons out in Wyoming at the that ranch out there. Tony walking around with his posse behind him and Bill walking around with his posse behind him. They'd pass each other in the halls and stuff. It was just kind of, I don't know, not real pleasant. It wasn't real pleasant. That group faded. It never really got the national input that the Academy did. Yeah, Kales, that's the guy. Yeah. They had an idea that was really different from what we had about what sleep was going to be. And I don't think it paid off for them like it did for us. But again, that kind of fronting for it, the charismatic nature of Bill DeMint, whom we dearly love. Another event dear to me was 1987 meeting in San Francisco. Bill, at that time, was a good friend of Stan Getz. And Getz, of course, subsequently died of lung cancer, but I don't know if he lived in Palo Alto. Anyway, he and Bill were real good friends. And Bill talked him into playing at the 87 meeting. And he was backed up by my son's jazz trio. We got to back up Stan Getz at the 87 meetings. It made me very proud. And of course, my son's still a musician in San Francisco, ASDC. I was involved with the ASDA, not with the CSS. I admired the CSS. I admired the idea because it went the right direction. But again, not everybody was happy with Phil Westbrook and the CSS. And of course, they all came together. Toward the end of my presidency, there were so many sleep fields, so many sleep organizations. There was the ASDA, the CSS, the NSF, the Sleep Research Society with from UCLA. So there was 4 or 5, and they didn't all agree with each other. So I invited everybody up here for a big wine tasting and dinner. I don't know if it ever came to any fruition, but I think people began to understand that we were all together. We weren't enemies fighting for space. There was plenty for everybody. And I guess if it wasn't for sleep apnea, I'm not sure that the whole thing would have developed the same. I know it wouldn't have, as a matter of fact. When I started now we're talking about the 70s, early 70s, a lot of lectures and talks and educational stuff. I went to the pulmonary department of my own school, where I was in the dean's office of one of the teachers, and et cetera, to give a talk on sleep apnea. And I started the talk, as I often did, with the catch line, "Snoring means airway obstruction." And I got a house full of laughs from the pulmonary department, believe it or not. They didn't laugh long, though. They started coming in because they began to realize that they had a field there. They had things to do there. But it was funny. They laughed when I said snoring means airway obstruction. I mean, in a way, some of that those concepts about about sleep apnea in the population, the general population. It's like, oh, snoring isn't bad. You snore, it's all okay. And it doesn't mean anything. Well, baloney. It's not healthy. It isn't normal to snore. So we succeeded after a lot of effort in separating off and trying to institutionalize the sleep book, Sleep, the journal Sleep, the board's exam, and we managed to do that. We separated those off, and gratefully got the agreements from Dr. Guilleminot, who was basically doing the sleep thing all by himself, and Ohio State, Helmut Schmidt, Dr. Helmut Schmidt, and they both sort of gave up their personal connections with those to a more organizational structure. And eventually we got sleep in as a subspecialty of medicine, which it wasn't. Some people, I guess, still don't think it is, but it wasn't. But it got boards, regular boards, and boards inside of a whole bunch of other fields, like pulmonary and internal medicine and neurology. I think everybody kept knocking on doors in Washington for some of it. There was a lot of connection there, and that knocking on doors was Bill. Bill DeMette. But other than that, I'm not sure of the process but that's where everybody was moving toward. And we had to get agreement from everybody about how to do that. The other thing that occurred, of course, is I remember that one of the first meetings we had of a show, the products, and the sleep apnea people, the CPAP people came. And it was a room about this big, and a couple of tables with Philips or whoever they were, with a couple of machines. That was the whole exposition. Within a few years, it was the basement of the biggest building everywhere, with people hawking in bags and giving people stuff. And an amazing transition from that. And I think that the companies that were involved in sleep stuff helped. Actually, they helped get it moved. They were also as involved in it as we were in medicine. They were making money off of it, so they wanted to see it survive. Yeah, well, it was during the ASDA, Sleep Startups Association, and the concept through the board was that we got a credit, and then two types of accreditation. One was as a complete center, and the other was as a sleep apnea center, which gave people the opportunity to focus on something and still be accredited and not have to have insomnia people and other people in their field. And then there was a division of the country, just because there were so many options, so that there were the Western states, and that's what I took care of under Helio. And we made appointments and went and saw people, hoping that they got materials that helped them know what it was they were supposed to be doing. But we walked into places that many of them were pulmonologists who had no idea about electrophysiology, for example, and how to record it. And it's kind of ironic in a way when you look at sleep medicine and the product that we use to make diagnoses, the polysomnogram. The polysomnogram has not changed. The field changed, but polysomnography hasn't changed. And there are all these people working on A to D conversion of the EEG and stuff. And you can do that. We can convert it, but the product is then put out in an analog fashion to look at. And so here we are 55 years later looking at the same data, and not really having a lot of advance from the digitization to help clinically. And so it's eyeballing by the doctor looking at that record that makes the difference. And we had to decide on criteria on how much is bad and how much is not bad. How much sleep apnea to have is a bad deal for patients. And that's all worked out many years ago now. And I retired from the university in 1985 and moved up here in Sonoma County to grow grapes and make wine. But I practiced clinical sleep medicine all the way up to 2 years ago. So I was involved with seeing patients and doing polysomnography for many years after I left the field. Well, I have a story that I tell about a pulmonary site visit at the Central Valley of California, a little small hospital. And the pulmonologist, who rightly saw that this was something he should be doing, and applied for a sleep apnea field approval. And we walked in, they had a polygraph machine, and standing next to it was a pulmonary technician who had no idea what was coming off that machine or anything. He just didn't know, and it was all noise. It was a total machine of noise. So you immediately knew this ain't going anywhere. And so rather than jumping on him and saying, "Oh, you're not good enough and you're too dumb and you got to," I just said, "Look, we can't accredit this, and you guys need to do this, 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 this." Listed it out for him, and eventually that lab did, and then we came back and accredited them as a sleep apnea lab. They still have one out there. Some of the bigger laboratories, they did things a little different, but not a lot different than from each other, from one another. I'm not sure exactly what to say about the differences, because we all were focused pretty much on sleep apnea, pretty much. Yeah, well, one of them is a person who's still a friend of mine, Sharon Keenan. Sharon started out as a tech, built all of that up, and then made her school and trained a lot of doctors. The other person who was important to me and a good friend was Peter McGregor. And Peter was a technician for us at Montefiore. He stayed there when Elliot moved up to Bloomingdale's. Peter stayed at Montefiore. But we had at the meetings, we had what was called the Tower Club. And I don't know if anybody else has run across that for you, but the Tower Club was, we met a group of people, mostly techs. Not as many doctors participated in that till later. We met at the tallest bar nightclub in the city we were in, whatever one it was. We went up there and drank and danced and had a good time. It was mostly technological people. Peter and Sharon and that group. But that was a binding force for us. That's a little harder for me because I wasn't very much involved in that. My buddy Max Hershkowitz was a lot more involved, and I'm sure he's got more to say about that. But I remember handing a check of, I think, a couple $100,000 over to start that. But I didn't really get involved very much in it. The what do you call club? The one had to do it from the book. Carol was dynamite. I mean, she was like a mother hen for everybody. She's a very powerful person. She picked the next director. uh, who was not totally successful, was not greatly beloved by everybody. But Carol was, pretty much. She ran things, a very powerful lady. I thought she was doing a good job when I was president. Well, I approached my practice of sleep medicine like I did any practice of medicine, right from the start. So it was a matter of appointments, seeing a new patient, history, physical, then decide what laboratory kind of tests you needed, follow up, an institution of treatment, and then follow those patients. And so it was pretty much a standard kind of outpatient practice. The inpatient never really took off. And I don't know if anybody ever, unless you were somebody who specialized in really serious cases of pulmonary disease or some neuromuscular thing or something where you needed to have a hospitalization. I didn't really hospitalize patients. It was all outpatient. And had sleep labs. Gosh, I had, at various times in California, I had 4 or 5 different sleep labs. 1 bed, 2 bed, 6 bed. Kind of expanded more and more and more. I think it's contracting at this point. They're starting to run together at this point, looks like. But I've been separated from the meetings and things for a long time now. Spending a lot more time up here and growing grapes. Oh, it was blessed. It was really blessed. I mean, we had patients who get tracheostomies and then have jewelry made around it and stuff like that. You know, I mean, poor guys had to wear a trach and then take their plug out, put their plug back, and it was not, you know, infection was a problem, I mean, a lot of the troubles with CPAP were exaggerated by companies trying to get in with some other kind of technique, but the CPAP was the thing that worked, and patients loved it when it worked properly and you got it fit properly. Oh my gosh, they'd say, well, I'm sleeping like a baby and I feel so much better, and their blood pressure would respond. And so it was the thing. It still is. There's a few things that have come along, but not much, really. And as long as we have an obesity problem. Obesity is related to sleep apnea. It makes it worse at the very least. There were some negative things. I mean, I've touched on a couple of them where there was a kind of a battle or a competition between people. And some people did worse things than other people, but I don't like to focus on that. I like to focus more on the fun things, like, you know, like having everybody up for a shark barbecue. Thresher shark. The AASM is define it, the National Organization for the Advancement of Sleep Medicine. And has been now, 50 years old, and seems like it's going to stick around. As organizations get big like that, in my experience in life, they tend to serve their population less because they get too big. But it didn't seem to be doing that. This brought a lot of people to information about sleep and sleep physiology, and so that's probably why it's still around after 50 years. A couple of therapeutic things. One is, over the years of trying to deal with people with insomnia and the development of algorithms for insomnia and stuff, one of the most common problems I saw time after time after time after time was people drinking coffee and not being able to sleep. It's like the effect of caffeine on sleep is just disaster. And nearly everybody that I was able to get off of caffeine got better. And it's simple, it's straightforward. You just let's do this first before we worry about MRI scans and stuff. Don't need all that medicine. Just stop that coffee. Well, doctor, I drink it in the morning. Well, they forget that eventually it was shown that the half-life of coffee is so long that it's still around when you go to bed at night, no matter what time you drink it in the morning. So that's one thing I'd pass along. And the other is to make sure that patients understand that CPAP can't hurt them. It just cannot hurt you. And it works when it's fit right. And of course, I've never agreed with the way some organizations applied it, HMOs like Kaiser. I never have liked the way they had put patients on CPAP and see them. You sort of like, because if it's not done right, then the patient doesn't usually stay on it, or they get upset by it. Like there's an ad goes around now. It's on television. This poor little guy's got a CPAP mask. He's throwing it around, and his dog grabs it and bites it. And it's an ad for the rest of the metal, sticking that piece of metal in you. I think it's a very rewarding field medically to be in. It's not, you don't have real sick patients very often, and you can get people feeling better and doing better and having a better life by being in there. And it comes from any field, pediatrics, pulmonary, neurology, psychiatry even. So I'd say it's a very rewarding field and not hard to get into anymore.